I would like to introduce Dr. Kevin Molloy, who's joining us from Dublin, Ireland. Well, he was here all week too, but we invited him to come over and share about quality of life. And one of the reasons that Dr. Molloy is really special to talk about quality of life is because he's been so involved on the clinical side. He's very passionate about quality of life for patients. He's been involved in something called the PROCLIPI project, which is looking at different kinds of prognostic indicators, but that also captures quality of life. And we've been collaborating for the last many years on trying to understand what is the true impact of living with cutaneous lymphoma on quality of life with individuals and families living with the disease, and how can we do a better job of understanding what everybody is dealing with and to maybe change clinical practice to better address some of those needs at the clinic and beyond. So he's done a lot of data research, and we've also done some collaborative work together in Ireland, which is great to bring these kinds of programs to Ireland, and he's been spearheading that. So without further ado, I'm just going to turn it over to you.
Thanks, Susan. You're very good. I think I'm turned on. You can hear me okay? So thank you, Susan. It's a privilege that I'm here to talk to you about quality of life. And it was we had an unbelievable session yesterday evening, listening to patient testimonials, and I came away in absolute awe after that last night. But my talk I've entitled "The Quality of Life: A Personal Journey." I really, it is a personal journey for all of us in terms of the patients and also doctors, and really I kind of want to take you through the journey of how I've come to look at quality of life and what I've learned along the way, because it's been a tremendous learning experience for me, and I'm delighted to bring the Irish and US connection together, because it always feels very natural that we work closely together, given our historic ties together. And I can't believe it's been 9 years since I was last in the United States. So it's great to be back. And when I was reflecting on this talk, I was kind of thinking about that American-Irish connection. And the Irish-American connection really was always about a journey of hope. And a lot of my ancestors and my relatives, one of whom will be joining me this evening for the 25th anniversary of the Cutaneous Lymphoma Foundation, really, when they moved to the United States, it was about a journey of hope. And I think that's where we're headed on in terms of what we're doing in relation to quality of life and patient-reported outcomes with cutaneous lymphoma, a rare disease. So the picture you can see there on the upper right-hand part of the screen is where I'm from in Ireland. And really, just to start the presentation, I'm just going to give you a little background about myself, who I am, and how I've ended up coming here and actually being here with you in the Cutaneous Lymphoma Foundation. These are my disclosures, and just at the very bottom, I said, all I know is that I don't know. And my uncle used to always say that to me. And we're learning all the time. So I went to medical school in Dublin, the Royal College of Surgeons in Ireland, and I then went on to do general medical training. Believe it or not, I started out in lungs. I didn't start out with skin, but my research career started out fairly early on in my medical training. And then life happens. You are going on a journey. And then something unexpected happened, and two of my dad and unfortunately his sister, there's a familial esophageal cancer in our family, and both of them were hit with that cancer, and things then changed. And unexpected, didn't see it coming, but then existential questions arise in your life, and you just have to reappraise where you are and what you're doing, and that's what happened. And that's how I ended up in dermatology, and how I ended up going to Birmingham, to the Queen Elizabeth Hospital of Birmingham, where I met Julia Scarisbrick, and where, surprisingly, became very interested in cutaneous lymphoma, and haven't looked back ever since in relation to my interest in the disease. And then I've moved back to Dublin in the last couple of years, and I've spearheaded with the great help of the Cutaneous Lymphoma Foundation to really establish cutaneous lymphoma service in Ireland, and also embedding patient advocacy and patient representation within what we do in terms of cutaneous lymphoma in Ireland. And also we collaborate in terms of research. Trinity College Dublin is our academic partner with the hospital I work in. So we're very lucky in terms of the infrastructural support that we have there. And serendipitously, you don't ever realize where life is going to take you. But if you look back, when I was 18 in my undergraduate medical studies, my first ever research project was on HUT78 cells, which turned out to be Sézary syndrome cells. So I've come a complete 360 in terms of where I started out and find myself back to where I began on my journey. So to talk about quality of life, we'd have to define what it is. And it's not just one thing, but it's defined as a state of complete physical, mental, and social well-being, not merely in the absence of disease. And it's a multi-dimensional construct. It's not just about health. It's about all the other things which can have a tremendous impact on our quality of life, including education, socioeconomics, work-life balance, infrastructure, et cetera. But when we define health-related quality of life, really we're talking about the subset of quality of life relating to the health of that particular individual. So quality of life is tremendously personal, and the reason I'm saying that at the outset is because when you start looking at quality of life research, you end up being buried in numbers. And the danger always is that when you're buried up in numbers, some of the meaning and significance of that to an individual patient sometimes gets a little bit lost, and it's always trying to bring that back and always bring it back to the individual patient that is in your clinic. And how we learn about quality of life, there's lots of different ways that we can do that. So we have various tools to learn about quality of life and, I suppose, generate data or numbers. We can do interviews, do qualitative research regarding quality of life. We also have questionnaires or instruments, which you may have experienced in clinic. We fill out questions and then do a rating scale, which very often generates a number, and that gives us an indication of different domains of quality of life. We also have surveys, including the Lymphoma Coalition Global Patient Survey. But also importantly, it's about the individual and about the affected individual themselves, but also their family and carers. And at the heart of all of this is all about family connections and the individual, because when something happens, as I've experienced in my own life, it can have a tremendous ripple effect, not just for the person affected, but also in the family dynamic in and of itself. So tools that we don't really have a specific cutaneous lymphoma questionnaire or instrument that actually kind of encompasses all that we need to do or capture in relation to quality of life, and that's work that's ongoing. And also in terms of decision aids, I think is something that myself and Susan have kind of spoken about, is how we bring all that together. So when you come to the clinic, that we kind of able to help bring up or discuss issues in the clinic that sometimes when you end up in that dynamic in the clinic, it's very agenda driven, and the dynamic usually only goes in a particular way, but it's how do we address that, or how do we open that up so that we learn more about what's affecting your quality of life more than just the disease in and of itself. Relation to health-related quality of life in cutaneous lymphoma. These are just some quotes from Benion's study back in 2015, and it really gets quite bad, and you want to scratch yourself to pieces. And itch and pruritus is a tremendously debilitating symptom with cutaneous lymphoma. Hair loss or alopecia can affect confidence and also physical appearances. In terms of function, and actually traveling to a hospital appointment or a specialist clinic can be a challenge. And in Ireland we've got a very different healthcare system, but we don't have the insurance issues as such. But certainly in the United States, I suspect that can be a challenge. And also in change in terms of the social aspect and interpersonal relationships with a spouse or a partner, or even within a family as well. So in terms of questionnaires and instruments, we've got loads of them. And the talk I gave yesterday, I actually went to the bother of counting up the number of instruments that was in the talk that I gave to summarize just in the last 4 years, not over time, there were 13 different instruments or 13 different questionnaires that were utilized to try and capture quality of life in patients with cutaneous lymphoma, which is staggering when you think about it. And you think about the fatigue that will bestow on somebody when you're trying to fill all that in a clinical setting. So we have cancer questionnaires, we also have skin questionnaires, and I said to you, we don't really have something that kind of blends all of that together, because what's unique about the disease is that you get skin signs and symptoms and the effect of all of that, but also you've got the impact of having a cancer diagnosis as well. And just to mention the surveys, and I keep badgering on about this, and it's because the more I look at the results of the Lymphoma Coalition Global Patient Survey, the more I realize how much really important information is in there. And when I look back on the 2022 survey, there was discussions there in terms of patient perception, and we talked about this yesterday. It says 84% of people hope for new treatments that bring a cure. 56 or half of patients fear about progression of their lymphoma. 6% of patients did feel involved in relation to decisions around treatment, but there's 40% of people that were missing out there in terms of being fully involved in their treatment decision, and also hoping for a longer survival from the illness. And also, this is a big thing about patient education, advocacy. Where do you get information regarding the illness? And websites seems to be the most reported or preferred source of information regarding thing. And the Cutaneous Lymphoma Foundation, certainly in Ireland, that's where I direct my patients to get information regarding the disease. And also concern regarding body image and appearance, which I've already mentioned. And also about 20-30% of affected individuals can have concurrent depression or anxiety in association with the condition. And what's staggering about this, and we're trying to do some work around this in Ireland, but 2/3 of patients are given the wrong diagnosis before the penny finally drops that they have a cutaneous lymphoma. In terms of questionnaires, I'm going to speak a lot about Skindex-29, and the reason for that is because Skindex-29 is the instrument or questionnaire that's used in the PROCLIPI studies. That's a big international study, which has now got over 2,500 patients that we're monitoring to try and determine characteristics of the disease which influence outcomes, one of which is quality of life. And with the Skindex-29, it's 30 questions in total, and the questions that I have up here all relate to symptoms, but it looks at also, there's emotional questions there and also functioning questions there. So as I said to you, PROCLIPI uses the Skindex-29, and there's 30 items in total. Now, item 18, which is not included in the scoring system, is subtracted from the questionnaire, so it's not actually regarded in the calculation of the score of the instrument. So that's where the 29 comes in. So even though there's 30 questions, item 18 is disregarded, and you end up with 29 questions, and that's really important. And I'll show you why that's really important later on in one of the slides. So there's 7 questions related to symptoms. There's 10 relating to emotions. There's 12 relating to functioning. And one of the observations that I find when I analyze the data regarding functional impacts of cutaneous lymphoma using the Skindex-29, I just don't think the instrument is terribly good at tracking that. And I think that the large part of that is because we're asking the wrong questions. And then we can use an average of that to try and get a global impression of quality of life. Now, doing that is a little bit controversial, but it's kind of happened just over the course of time in the medical literature about averaging those scores to give an overall impression of quality of life. So back in 2020, when I first got involved in quality of life research with the PROCLIPI study, it was actually 2018, but when we published this back in 2020, we looked at various factors that might influence quality of life. So is there any particular characteristics about the disease or the patients which influence whether somebody's got worse quality of life or not? And female sex was one where we identified that quality of life was worse in female patients, and we see that across other diseases as well, like skin diseases like psoriasis, for example. Sézary syndrome and late-stage disease were also associated with worse quality of life. LDH there is a blood marker, or lactate dehydrogenase, and that's probably just a reflection of, again, more advanced disease. Really interestingly, hair loss came across as a significant factor as well, particularly in the emotional domain, and also red all over was also a really important factor as well. So when you're looking at data, you can look at factors individually, or you can try and combine them all together to see which ones are more important, because different factors compete with one another to influence a quality of life. So when it comes to that, we do what we call a multivariate analysis. So basically, we pitch all of those factors together, and then we try and see from a statistical standpoint which ones are more important than others. And female sex, alopecia or hair loss, and also redness all over were the 3 independent factors which predicted a worse quality of life. And one of the things that we did was that we looked at, was there anything in relation to female sex that was more troublesome than their male counterparts? And we were able to find there were more symptoms, more experience of emotions such as embarrassment, shame, etc., and also disturbance in sleep. So we were able to drill down into the questionnaire to try and find factors which influence that outcome. And I think that's what's always really important, is when you do these questionnaires, you end up with a number, but it's finding out, well, that number is high, and then we need to go back and ask ourselves, why is that number high? Because that might give us an indication of what might be going on to drive that quality of life score for an individual. With PROCLIPI is prospective, so basically we're following those patients over time. And the question is then, does quality of life change over time? And if quality of life does change over time, why is it changing? Is it changing because of treatment? Is it changing because there's adapting to the disease, or the coping becomes better in terms of coping with the disease? I think the truth of the matter is, at the moment, we don't know. But what we do know is that we do know the quality of life when PROCLIPI gets better, and certainly between the first visit, which is within 6 months of diagnosis, and then the second visit, which is after 12 months, the quality of life does get better. Then it seems to flatten, and then about visit 5 or so, we see a slight improvement then again. And we don't really know why that is. So one of the things that I looked at in the past was that we know the quality of life gets better, but what's changing? And one of the things that we looked at was itch. Is it pain? Is it worry? Is it sleep? And to look at that, it's very difficult to look at that from a very statistically sound point of view. But one of the things, just a very basic thing I decided to ask was, is there any individual responses that might be telling us what's really important when people are filling out the Skindex 29 questionnaire? So what I did was we grouped anybody who rated an individual item on the Skindex as often or all of the time, and then figure out what percentage of people reported that as an outcome for the individual questions. And by doing that, we were able to rank the top 15 or top 10 items on the Skindex 29 questionnaire to try and tease that out about what is really important. And actually what's really interesting was that the emotional items were ranked the top 2. So it's worry that the skin condition it might get worse, or worry that the skin condition may be serious. And then skin symptoms come in terms of skin itch, sensitivity, and irritation. And then symptoms like annoyance and frustration, affecting sleep, being angry about the condition or embarrassed about the condition then start to filter in. And then I worry about side effects from my medication. And remember I said to you before, in a few slides before this, that item 18 on the Skindex 29 is completely disregarded in the calculation of the score or quality of life score. And actually that's coming up as one of the really important items in the Skindex 29 score. So, and this is the thing, the difficulty always when you're compiling numbers together, is that some of the things that actually are meaningful, you're missing them unless you look really, really closely to drill down into that information. And then feeling depressed or tired, and fatigue. Interesting, when Susan and I held the first patient seminar on cutaneous lymphoma in Ireland last year, we asked people to make comments on the feedback, And it was very interesting that when we look back at the thing, fatigue was something that was coming up on the feedback we were giving, that we were given. So it's a really important symptom as well in relation to impact on quality of life. So in terms of what's changing, when we look at the change or improvement of quality of life between the first visit and second visit, is that these are the things that we seem to having a positive effect on in terms of that worry regarding seriousness or worsening of a skin condition. That may be reflecting of some adjustment to the diagnosis and actually getting the right information regarding the condition to help with that. And also some of those skin symptoms are also getting better. And the red here is the emotional items, and then the it looks like green or blue there are the symptoms, and then the green is the functional stuff. And then there's some stuff that we're just really not having a major effect on in terms of we're not doing much in relation to sleep, shame, anger, depression, or embarrassment. But what seems to be getting worse is, or not doing anything at all with, is skin bleeding, worried about getting scars, humiliation. And you can see the number of functional items that are here in the green. Actually, we're not doing anything about those. And remember I said to you the functional aspect of the Skindex 29, and I think that's probably because we're really just not asking the right questions that are relevant to cutaneous lymphoma. Or maybe it's a reflection of the data. For example, that maybe in just early stage, maybe it's not having a huge impact, or we don't know yet. But I think that in the years to come with PROCLIPI, and you look at the number of data entry points we have in PROCLIPI now is quite significant, we may be able to answer some of those questions in a little bit more detail. So the question always comes is, what are we missing? We know quite a lot now in relation to, things that impact in terms of, the various parts of the Skindex 29 questionnaire that are important, and I've kind of listed them all here in a kind of a jigsaw puzzle diagram. The skin symptoms, worry about the condition getting worse, seriousness, interruption of sleep, etc. And also side effects of treatment, again, actually is important, and I put that down there. But what are we missing? There's stuff that we should be asking that we're just not asking. And this is where it comes back to this slide that I showed to you previously, is that we have cancer questionnaires, we also have skin questionnaires, and it's about bringing all of that together that incorporates both a cancer diagnosis and also a cancer that affects the skin and has some of the impact of a skin disease. So the cancer questionnaires tend to be too skin specific, whereas the skin questionnaires are, too cancer specific, and the skin questionnaires tend to be too skin specific. So it's about bringing all that together. And we're doing some work at the moment to try and develop a cutaneous lymphoma instrument. And we're doing this with the EORTC quality of life group. And to do that, we interviewed, it was actually 66 patients in total using semi-structured interviews, using a pre-compiled list of 102 different issues, and asked patients to rate those in terms of relevance and also importance, to try and narrow down all the issues that are relevant to somebody who's affected by cutaneous lymphoma. And it takes place over the course of 4 phases. We still have a bit of a way to go, but we're currently entering into phase 2, having looked at and identified issues that are important. And this is a long list of issues that we've identified in the work that we've done. And you'll see that we've interviewed both patients and healthcare professionals. And what's very interesting is when you interview healthcare professionals, the healthcare professionals always seem to rate everything much higher than individual patients. And you get a much more individualistic impression of quality of life from the patient. But when you go to the healthcare professional, they're rating everything really, really, really high. So you have to try and, work that out then when you're doing trying to select what is important. So you give a much more stronger weight to what the patient says compared to the healthcare professional, and that's what we had to do here to try and pick out what's important. But just to highlight the ones that we've already picking these out in the green X here on the Skindex 29 and what we do with PROCLIPI. And these are the other emotional aspects or functional aspects. and also feeling tired is coming up there in our issues, and then all of these other ones as well, which are actually not having a tremendous effect on in the PROCLIPI study. So really then it's all about bringing all of this together. Now when we were doing these interviews, we were asking, after going through the exhaustive list of 102 issues, the question then was to the person we were interviewing was, what are we missing? Is there anything else that we're missing that's not included in those 102 issues? And that's where it always got a little bit tricky, because we were always a bit exhausted. So we really had to push people to tell us what's important. And what's really interesting, there was some really interesting stuff that came up there in terms of burden to travel for healthcare business or visits and treatments, and also sensitivity to temperature changes. And this has come up time and time again. And even in a clinic letter I received very recently before I came across here, it was listed as an important thing for a patient affected by cutaneous lymphoma. And also alopecia or hair loss was also something that came through. So we had to figure out how we handled this. And I pushed really hard to make sure, because what would happen is if we applied statistical or mathematical principles to all of this, we would lose these really important issues from the work that we've done. So I pushed really hard to retain all these issues in the questionnaire as we move things forward. And the reason for that is because I think if it's brought up by an individual affected, that's way more important than any mathematical or statistical model, and we must maintain that and not lose that just because of for the sake of some sums. In relation to developments since 2020, we spoke about this yesterday, but there's been a tremendous amount of work looking at different aspects of cutaneous lymphoma, specifically including cutaneous B-cell lymphoma and also early stage mycosis fungoides. There's been studies looking at biological sex, which reinforces the findings that female patients are more severely affected, which matches what we saw in the PROCLIPI study. There's been some really nice work done in relation to skin of color and the effect that cutaneous lymphoma has on quality of life in patients with skin of color. And body site involvement is also really important. And it was when I read Mishi Shinohara's paper looking at quality of life in her patients of 272 patients, I think it was the number. What was really fascinating about that was that if the disease affected the hands or the genital area or the head and neck, it had a significant impact on quality of life. And that's what we call high impact sites. And we see that with other skin conditions such as psoriasis or eczema, where you get these high impact sites that even though the percentage body surface area affected is not huge, it's where they affect, and the functional consequence of that is so huge that it is a tremendous impact on quality of life. And really, I think we need to look at that more closely, because when you look at skin scoring for cutaneous lymphoma, that yes, we do look at site, but if you convert that to a number and just look at the number, you miss out where the site of affected disease is. And I think we need to look at that more closely. Itch, there's been, again, reinforced the importance of itch, and itch always seems to correlate with these quality of life instruments that we use to measure quality of life in our patients, and also treatments. And this is one of the questions that we need to answer, and it's really important that we answer this question, is that if we're giving a treatment to a patient, obviously we want to make the condition better, but not to the detriment of quality of life. So I always demonstrate this graph where the treatment must be efficacious, have minimal side effects, and actually have a positive impact on quality of life. And some of the treatments that I've listed there have examined quality of life, and there's been some positive improvements in quality of life as a result of those treatments. So in relation to where we're going, I think that there's scope now, I think, to try and bring all this together, including people who are interested in quality of life, to really sit down and look at everything that we know so far. Because in the last 4 years, we've learned a huge amount in relation to quality of life in this condition. And we need to sit down and take a bit of a breather and a step back and actually distill that down to see if in the future, when it comes to examining this, what we should be looking at. And I've listed some of the stuff here that we should be examining. And again, I mentioned again the global patient survey, because there's a huge amount of stuff in there that I think actually gives us plenty of ideas and scope about other aspects of the disease that we should be looked at. Diagnostic delay, as I said to you, 2/3 of patients who answered the 2022 survey was a major issue for patients. And also in relation to the skin involvement, it's not just about the extent or how much of the skin is affected. I also mentioned then again, and I reinforce this, and this is really important because it was a bit of a wow moment when I realized this, is high impact sites and where is affected, because that's really, really, really important as well. And obviously itch, as we've mentioned, and also the disease itself, what stage it's at, and also the impact of treatments. So in relation to coming to a close on my slides, I got a bit of a slap on the wrist back in 2019 by a very esteemed and established cutaneous lymphoma expert when I presented some of the data from PROCLIPI, where it was very heavy on numbers. Now, it was inspired by the very lovely architecture in Greece at the time, but it was a really important lesson for me that it's really important that we don't get just obsessed too much about numbers. Numbers are nice, and it's nice to see numbers getting better, but it's about bringing that back to the individual and the person. And again, as I said to you, as I opened this talk, it's about a personal journey and quality of life for an individual. And I suppose, in terms of, I came up with this concept yesterday, and I said to people, you might love it or hate it, but it's to try and get an instrument or a way of pulling all this information together that we can predict that what somebody's quality of life might be, and there's various ways we can do that. And again, comes back to patient interviews, instruments or questionnaires, and also surveys. So this is a nice image that I got, and at the top it's written in Irish, Nínearca Curlicala. Basically that means that there's strength in unity, and I think that is really the how we get things done and how we learn more about the quality of life in this condition. Promoting awareness, providing education, advancing patient care, and also fostering research as well. And there's part of the mission of the Cutaneous Lymphoma Foundation. And I think that's how we advance understanding quality of life with cutaneous lymphoma. So I had a moment back in Ireland about a few weeks ago. We got a very rare bit of sunshine, which we haven't really had in the last 18 months. And I was quite excited to get out and actually capture the sunset not too far from the house. So I thank you for your attention. I'm happy to open up the discussion and take any questions. Thank you.
Thank you, Dr. Molloy. So we've got some time for questions, and I know we're monitoring our home audience too, and I see Dr. Tallaght is here, yay. So I know that was probably a lot, and I know I try to, you probably have received from us, answer the global patient survey, but this is one of the reasons why, and this is what happens to that data that gets collected and how it gets input into all of these other pieces and parts of delivering hopefully better care for all of us, and how we can work better with management of the disease and things like that. So anyone have any questions you'd like to ask? Things you'd like to know? I don't know if I'm allowed to let you ask the questions, Steve. Steve is the research director at the Lymphoma Coalition, so the Global Patient Survey is his baby, and he's responsible. Sorry.
Yeah, I am. Yeah, I am. Thanks for the presentation. That was great. And thanks for you using the data to generate something like this. I have a question, and I'll just preface it by saying, do we need another PRO, right?
Yeah.
And because there are so many, as you've said. So one of the questions I have, and that we have struggled with the Global Patient Survey, is cognitive burden. We have 170 questions potentially.
Yeah.
How do we simplify this? How do we consolidate these instruments to make them easier for patients, especially as they're progressing, when we're increasing the frequency of the asks for them? Do you have a strategy for that, or can you comment?
Good question. In relation to, do we need another patient-reported outcome measure? It's a good question. I think there is a need for one. I think there's one that, in terms of, and I think this probably feeds into the answering of the other question. I think that the fact that there are so many different instruments and so many questions is that we've never actually sat down in a methodical way and tried to develop something very specifically for cutaneous lymphoma. And that's why the work of the EORTC Quality of Life Group is so important, because we've a way to do that. But the only thing about the fatigue around filling out surveys, it's very, 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 very tricky. And I'm going to be very honest with you, I don't have a strategy on how we deal with that. And I'll be honest with you, I get tremendously fatigued as well, looking at the literature and trying to figure out what instrument is doing what for in terms of measuring quality of life. And I think that's something where patient representation and actually the voice of the patients come in. And this is why I'm really strongly advocate, public and patient involvement in research, particularly around this area where we should be doing research by and with rather than to and for patients. And I really don't think it should be me deciding what we should be asking or how we should be asking it. And I think that's where the patients come in, and I think the patients should be telling us what we should be asking and how we should be asking it. And I think we really need to figure a good way of doing that. Yeah.
Oh, thanks. That was a good question. It was also a thing that was discussed in Madrid last year. I sat on a table with people also from the UK. It said, well, they were sometimes half a day busy with the questionnaires. Yeah. But what I heard, it was yesterday, I think, was Dr. Cohen with his electronic.
Yeah.
Wouldn't that really be
100%.
Also an answer?
Yeah.
He had a very good, solid presentation.
Yeah, I think the EPROM, certainly with his response rate of 76%, where electronic patient report outcome measure, anything that makes it simpler for somebody to fill it out, and ideally, outside of that consultation environment, because I think when it's very interesting, the very first interview that I did for the EORTC Quality of Life instrument, myself and the patient had a very nice discussion at the end where they talked about the dynamic of a consultation. And it was just like, it was always very agenda driven and driven with a very specific outcome in mind, which is you come in, all the bits that you need to be done in clinic are done, and then you're out the door again. And it never gave the opportunity to ask or discuss other things that they wanted or needed to be discussed in that consultation. So having an EPROM or having somebody fill out a patient report outcome measure before coming to a consultation gives the opportunity for the patient and also the healthcare professional who's going to be doing that consultation an opportunity to reflect and have a look. Is there something else going on that I need to try and bring up or discuss during this consultation? And when you're doing a quality of life assessment in the clinic, and certainly my experience always is, it's that little bit at the end that you have to do. And usually, when it comes to dermatology, you're doing the quality of life assessment because part of that quality assessment helps give you access to different therapies or treatments. So it's that little bit add-on of the consultation, which is vitally important, but actually by doing it electronically beforehand and having that information available before you come into the consultation would be tremendously helpful. Now, the difficulty around that is just infrastructure and having the infrastructure to be able to do that. And certainly, I'm going to speak from an Irish context. We're way off being able to do something like that in Ireland. But I think if your healthcare system is digitally enabled and you're able to do that, I think it's a fantastic way to capture that data as well. Yeah.
So we have some questions from our audience, our virtual audience. So we're going to go to the virtual and then.
So this is sorry about that, a practical question. What about sunburn issues? Sunburn on patches or plaques?
Getting sunburn on patches or plaques. I wouldn't advocate getting any sunburn, to be honest. Getting sun is okay as long as you're sun safe and that you don't burn. Sunburn is always an alarming thing, certainly for us in Ireland where we've got very pale skin, because sunburn is an indication of your sun not able to cope, or your skin not able to cope with the amount of UV exposure. So I think I wouldn't advocate getting sunburnt, but a little bit of sun, provided it's safe, it shouldn't be an issue.
I'm a care partner, and so I haven't had to do the questionnaires myself, but I have been there, and there seem to be a little postscript in the visit at the end, and they do seem, I've wondered myself, what happens to those?
Yeah.
Where do those go? And also, I know visits are they're such valuable time.
Yeah.
There's always this anxiety for patient and caregiver of, using every second to ask things that are really needed. So
Yeah.
they do seem to be in a little bit of a silo of their own. And I wonder, as you're developing a new tool, is there room to have it replace some of the others so that it's not just adding, but consolidating, so that there's fewer, more efficient?
Yeah, I mean, in terms of the methodology that we've used to develop the new survey, I mean, that's what we have in mind, is that it's a consolidation of what we already have, so that it becomes simpler. And the thing about it is that, yes, we'll have a new instrument, but there's always going to be instruments, and there's always going to be different instruments. And I think what really needs to be examined is which instrument, in comparing one to the other, actually give us the best representation of impact of quality of life. Now, one of the things we observed with PROCLIPI, and I asked that we added in a global rating of change score into PROCLIPI. And the reason I did that was because these scores and these numbers and these quality of life instruments are only useful provided that they're clinically meaningful. Does that score or change in score mean something to a patient? This is always a big issue regarding using these to track response to treatments or track the disease. So we've done that with that purpose in mind, in terms of actually asking the patient, how do you feel today? Actually, is your quality of life better today compared to when the last time I saw you? And just asking a very open-ended question, because because you can use all the statistics and mathematics in the world, but if you're not asking somebody outright, are you better, are you worse, or are you the same, then the scores actually don't mean an awful lot. And I think that's why I pushed hard. And I look at this yesterday morning, and we've over 1,000 of those responses in PROCLIPI now. So actually, hopefully, we'll be able to get some clinically meaningful out of that, means something to the patient. Just to go back to your point about the add-on bit at the end of a clinic, I think anything that we can do to give back more time during a consultation, to allow more of an interaction, more discussion, more questions, whether it be an EPROM or some other way, I'd be 100% in favor of it, because that time is precious. And anything we can do to give back that time has to be positive. Has to be.
Deb, we
have a few more from online. Have you found it difficult to share survey findings of significance that could have an impact on how CTCL patients' treatment protocols are determined? How are they usually received?
Say that question again, sorry. I didn't quite follow it.
Yep. Have you found it difficult to share survey findings of significance that could have an impact on how CTCL patients' treatment protocols are determined? And then the second part is, how are they usually received?
In relation to treatment, we haven't specifically examined the data and quality of life impact of different treatments in PROCLIPI as yet, and actually that's going to be part of another big bit of work that we have to do. And it may be difficult and difficultly challenging how to examine that well, because when you have a treatment and an impact on quality of life, that measurement of that quality of life has to be somewhere in terms of timing around the treatment given and the response to that treatment, to try and match all of that back. I think that's really all I can say on that one.
And then the next one is, how is the insurance aspect in the US versus UK versus Ireland play in the quality of life?
Yeah, it's a good question. No, we don't have, I mean, the Irish, I can't speak to the UK. Well, I could speak to the UK, but I'm not going to, because I don't work there anymore. But I can certainly speak to Ireland. So Ireland is a very frank two-tier health system. So we have a public health system, and we also have a private health system. So private health insurance in the Republic of Ireland is entirely voluntary. You don't have to have private health insurance. The difficulty regarding healthcare in Ireland is always about access. It's access to care, because there's a huge delay from the point of referral to actually accessing healthcare in Ireland. And the private health system, in a way, kind of gives you those benefits of skipping the queue to an extent, about getting quicker access to a consultation, an investigation, or a treatment. Now, what I do with cutaneous lymphoma in Ireland is that I have done a lot of work in the last 18 months. So I have developed a rapid access clinic for cutaneous lymphoma, which is specifically designated for cutaneous lymphoma, so that it's all done as an extra, an add-on thing for me. But the purpose around that, and it goes back to the conversations that we've already had, is to, on that first consultation or the first point of referral, is that we have plenty of time to have a good long discussion regarding the diagnosis and investigations and treatment.
Okay.
We have one more.
Oh, we have one more. Okay, Deb, go
Okay.
ahead.
Is there any statistics for people of color, as this individual has only spoken to 3 people and they are all from the United States?
Yeah, there is statistics around impact of quality of life and skin of colour, and we do see that quality of life is more significantly impacted in patients with skin of colour. We don't have that data on PROCLIPI that we've analysed yet in terms of the quality of score, but certainly there's a big impact in relation to skin of colour. Yeah.
Okay, since they're talking, I'm going to follow up. The person that was asking about the sun, they did a follow-up, and they said that anytime they are out in the sun, they get burned.
Okay.
And they must wear UV clothing.
Mm-hmm.
So that's what I have, but I'm wondering if they're wondering, does the patches and plaques are they more sensitive to the sun than like regular skin?
Yeah, potentially. I think if you have anything that increases redness of the skin, be it heat or warmth, I think the patch to plaques may look worse. I think that in relation to the question regarding needing to use UV clothing and sun sensitivity, it's probably best to discuss that with a treating dermatologist, because there are reasons as to why they might be very sensitive in sunlight. A thought that came to my mind there is, for example, when you have a shower and your skin is warm and hot, very often people come out of the shower and they kind of go, the shower has made my condition worse. And it's not that it's gotten worse, it's that the increase in temperature and blood flow into the skin makes the plaques or patches look redder. And also if you moisturize on top, initially it might look like it's become brighter or redder, but it's the fact that the moisturizer or the glistening effect on the skin actually makes it look more intensely red than it would be otherwise. And it's the way the light reflects off the skin in that way. Yeah.
So there was, I'm not sure if it's necessarily a question, but more of a statement.
Okay.
The individual said, I believe monitoring quality of life is a great concept, but I'm struggling to grasp what comes next.
That's a good, I think we're still struggling too.
We're still struggling with that one.
Right.
Yeah. No, quality, it's really, really, really important, but I think in terms of what comes next, and it goes back to this thing about clinically meaningful, and what does it mean to individual patients, and actually what it also means to a group of patients. And especially, I think in terms of utility, in terms of quality of life instrument, really comes down to a lot about our therapeutics and what we do to intervene to improve quality of life, and whether anything that we do to intervene, be it a therapeutic or a non-treatment option, actually does that have a meaningful benefit improvement to quality of life for an individual. Yeah.
Thank you very much.
You're welcome.
Really appreciate that. So you got a little insight into what Dr. Molloy was sharing with the clinicians over the last couple of days at the World Congress. So I think one of the exciting things is that it's a high focus of the clinical community, and in cutaneous lymphoma, and everyone's very, very interested in how do we do a better job to help overall quality of life beyond just the therapeutics, right? Beyond just throwing a treatment or another topical or something. It's what's that whole impact, and then how do you create a better environment for a dialogue between the individual and the clinician to really make sure that we can all do the best we can, even though everybody is living with the disease. How do we make that life better? And we still have a lot of work to do, but you all play a really important role in providing your feedback and giving your perspective, because that's really where the rubber meets the road. It's all about you. And if we can't capture that from you, then it gets done in a vacuum, and then we don't have that kind of impact. So please keep answering the surveys if we ask, but you can tell us if we ask too much, because we're trying to do our best. But your voice matters, and it is making an impact, and it's really being listened to. So thank you very much. I need to grab